panel, we really look at other themes beyond just COVID. We look at WASH, we look at health, we look at access to information, and so on. So what we do, we design that tool, and then once it's scripted, then we use the CATI, that is computer-aided telephonic interviews, and then have our call center team reach out to these respondents and collect that data. At the moment, we are all at home, so that teams are at home and they're able to do this efficiently, and we've put in a number of measures to ensure that the confidentiality of our respondents is respected. So once we have collected the data, we analyze it and then share in official launches such as this one, but also to let you know that once we have shared this data, our publications are available on our website, and the data can also be accessed, and you're able to use it free of charge. All we ask you is to acknowledge that this is from the Twaweza Sauti za Wananchi. And we also do targeted stakeholder outreaches in closed spaces where we are probably not able to go at in an event such as this. So for our findings, we asked, what actions can you and others take to protect themselves and others from contracting the coronavirus? And from this, we saw that residents focus on hand hygiene and mask wearing as the key measures to protect themselves against contracting the coronavirus. This we have seen in the 3 districts, that is Kampala, Kyotera, and Tororo. We also see that they are talking about staying indoors and only going out if it's necessary. They're talking about maintaining the social distance, avoiding contact with non-household members, and so on. So that is, in principle, what they say that they can do. So in practice, what is it that they do? So looking at the last 2 weeks when we collected this data, we asked what actions have you or your household taken to protect yourselves from contracting the coronavirus in the last 2 weeks. And again, we see here that there is a high mention for sanitizing and washing hands. There is a high mention for wearing masks, then also staying indoors. There's also a fairly lower mention, let me say about 3 out of 10 that say that they maintain the social distance. And if you compare with what we have seen in terms of what they say that they do, this is lower, because in what they say that they do, it was 47% that say that. But in practice, those that have really done this, it's only 32%. We also see a difference in other areas, such as avoiding public gatherings. We also see, again, a slightly lower practice in terms of avoiding public transport. So many more say that yes, this can be done, but in practice, there are a bit more that are actually going ahead, and there are less that are going, there are more that are actually doing the issue of avoiding public transport. So in looking at this, when we compare the data that was collected last year around July, we did see that there was some change in Kampala, Kyotera, and Tororo in terms of washing hands and sanitizing. Because, for instance, in Kampala, we saw there was a higher mention of those that are doing this, from 87 to 90%, small but higher. Same with Kyotera, about a 3% increment. And then in Toro as well, we did see some increment in those that are saying that they're washing hands and also sanitizing. Then when it comes to the wearing of masks, we also did see that there was an increment here in the number of people that are saying that they are doing that. Last year we had about 72% that was saying that, and now we are seeing they're 86. Then for Tororo, there was 65% that was saying that they are doing this. last year, and now we are seeing 85% that are saying that they're wearing the masks. Then when it comes to maintaining the 2-meter distance from other people, that is social distancing, again here, we see that this more people have taken on this practice, where we see that now we have 32% that are saying that. Last year, we had 21% that were saying that. That is in July last year. And then for Chotera, we had 15% that were saying that last year. And now we have 28% that are saying that. Then when it comes to Tororo, we had 30%. We have 30% that are saying that this year, and last year we had 23%. Then again, we are seeing that in terms of those that are drinking ginger, lemon, and honey, that is remedies made at home to ensure that they don't contract the coronavirus. This, we have seen a very a huge increment. Last year, we did not see people mentioning that, but now we have 27% mentioning that in Kampala, then 19% mentioning that in Chotera, and then 14% mentioning that in Tororo. Then when it comes to the alternative remedies, this is something that we focused on a few weeks back. But from this data, we see that for the 3 districts, the number has actually doubled in each of them for those that are resorting to steaming as a way of preventing themselves from contracting the coronavirus. So what is it that motivates them to adhere to these standards, both the standard operating procedures and also the other measures that they're taking, they're doing? We see that what motivates them is really pretty much to protect themselves against getting the coronavirus. And there's a bit of fear of death in there as well. So when we look at, in terms of the risk, in their opinion, which places do they think someone is more likely to be exposed to the coronavirus? We see that the residents of these 3 districts are saying that the workplaces and urban areas are really the key locations where they think that they'll be exposed to the coronavirus. There are other mentions of schools and colleges. This is mentioned by about 35% of the residents of Kampala, and then about 2 in 10 of the residents of Chotera and Tororo. Then public gatherings is also mentioned by about 3 out of 10 in Kampala and Tororo. Then at the border points, you also see those that reside in Kampala and Chotera mentioning those areas being points of risk for them. Then in densely populated residential areas, and they also mention in cold areas. That is, this is mentioned more by the residents of Kampala. What we also found a bit surprising in the data is that unlike other data sets that we have looked at since we started doing this data collection specific to COVID-19, now we see that there is a mention of those prisons and police custody as an area where one can easily be exposed to the coronavirus. And we see 17% mentioning this in Kampala, 13% mentioning this in Chotera. Very few mention that in Tororo. So it's something that maybe at some point we can probably look at. Why is it that they think that? Then they also mention places occupied by foreigners. This is mainly mentioned by the residents of Kampala and Chotera, that these are places where someone can easily be exposed to the coronavirus. There are other lower mentions like water points, shopping centers, and also when they're exchanging money. So we asked another question to understand understand suspected coronavirus in their family or among a health worker, a health facility. With the exception of Tororo, where we see that 3 in 10 mention that they would go to they would contact the LC1. The other locations, about 1 in 10 would say that they would contact the LC1 in case they had someone that has contracted or they suspect has contracted the coronavirus. Then we also see that for those that reside in Kyotera, about 10% say that they would contact the COVID task force within their district in case they got a suspected coronavirus case. So what would they do if they suspect that they have COVID-like symptoms? And here we see an overwhelming number, a high number, almost 8 in 10 for all the 3 districts that mention that they will visit a health facility once they suspect that they have corona. So this question was a multiple mention, and there are other mentions that were given. Self-quarantine, which is much lower. Some would treat with herbal remedies, which is again much lower. And we see more of this in Kampala and Kyotera compared to Tororo, where we see only 7%, while the other 2 are in the 20s. Then we see those that are talking about self-treatment, that is with their own medication, maybe from over the counter, that is about 14% in Kampala. Then those that would use the steam inhalation, again, more of those in Kampala compared to the other 2 districts. Then we see that when it comes to those that would call the corona hotline, 10% said that in Kampala, and then 4% said that in Kyotera, and 3% said that in Tororo. From the data that we collected again around the same time last year, this for the hotline, the corona hotline, the mentions were much higher because we had about 58% mentioning calling that line in Kampala, then 61% were mentioning calling that line in Kyotera, while now we see it's just 4%, and then about 37% saying that they would call that line in Tororo. So generally all others, they are still pretty much doing the same, visiting the health facility and so on. But for the hotline, we see that there is now a decline in those that would take up this, this platform to get information on what to do once they have a suspected coronavirus case. So over this period, since we started collecting this data, we have seen that when it comes to the number of families or percentage of families or households that say that they have had a COVID test done, this has increased across all the 3 districts from about 15% to now more than 35% on average for the 3 districts. And again, it probably, this takes us into the issue of what happens when they go to the first point they mentioned, that is the first alternative, which is going to the health facility once they have a suspected case, that probably a test will be proposed to them. And again, we know that we've seen testimonies from some citizens across the media saying that some of these tests are quite expensive. Then we've also had differing information on the cost of the tests. Some are saying 80, some are saying 200, some mention 500. So clearly there will be need for more information on this. And then so that people can know what to anticipate when they get to those facilities. Because it's quite likely that when someone goes to a facility and then they are told that you're going to take this test, it's going to cost this much, they probably opt not to take that test. Or for some people, if at all they go to a health facility and they are given an option to take a test of probably 60,000 or 80,000, they'll still take that test and then consider themselves negative, yet it might not exactly be the case. So I'm looking forward to what the experts are going to share with us this morning. So to conclude, in summary, hand hygiene and mask wearing are the key measures that residents are taking up to prevent themselves from contracting the coronavirus. Then we have seen a noted rise in the mask wearing compared to a year ago. And when it comes to what they do in regards to the SOPs, they do mention a number of them, they are aware of them. But when it comes to what they actually practice, we have seen that this differs in terms of the social distancing. They know that it happens, but they don't exactly do that. The public gatherings, they know that they should not go there, but we still see that some of them actually are going into some of them. For example, burials, they probably do not consider that as a public gathering at that point because they're thinking this is family. Then also the use of public transport. This is not from our data, but we have seen if you move along the streets that some people actually still taking the borders. Then in terms of what they consider as the risky locations, we've seen the urban areas and also the workplaces, but also a surprising mention of prisons and police custody. Then, whereas visiting the health facility is the first action taken in case of a suspected COVID case, and we have seen that so many other measures have been put in place to assist Ugandans to get information quickly. We have seen that there is a drop in those that mention going to the call center or calling the call center to get information. And we have seen that overall, since the onset of the pandemic, we have seen a rise in the number of those that are taking up the tests, in as much as most cases we find that the tests that we are taking in Uganda are paid for by the citizens. So with that, I want to hand over to the MC. Thank you once again for listening.
Thank you, Mali, for that presentation. It takes back to our panelists. I think you have something. It would be fair enough if you make comments on this presentation. Specifically, the study first tackles the issue of observing SOPs. I would like the population and the people online and people here to understand what's the relationship between observing SOPs and COVID-19 testing. Is there any relationship? Does it in any way ease your work of testing? Then the issue that comes up again is what informs the increase in the number of people being tested from July and August 2020 to June and July 2021. We see a slight increase. What informs that increase? And maybe any other observation that you've seen that you'd like to tell us before we can draw back into our discussion. I'll start with you, Dr. Susan.
Thank you very much, and I'd like to thank the presenter for those very good observations. One of them is the increase. People are aware of the SOPs and which SOPs have been put in place but as you see the following the SOPs, the percentage that is following them is around 32%. What does that mean on the side of the testing? If you follow the SOPs, you are reducing the chances of spreading the virus from one person to another. And because if someone gets the virus and gets the symptoms, they'll then come to hospitals. You've heard that there's an increase in the number of people coming to hospitals to get the testing. But if we follow the SOPs, we shall reduce the spread of the virus, then hence we shall have few people that will have the virus, then hence few people that will need to be tested. So if we really observe the SOPs very well, we can reduce the burden of those that are supposed to come for testing. And why the increase in the testing that we are seeing right now? As I'll talk through during our discussion, one initially, like last year in May, the testing was really focused around importation, truck drivers, quarantine. So there were specific categories of people who were testing. And that time, the transmission was not as diffuse as it is now. Now we have diffuse transmission, and you've heard that anyone who has any symptoms, their first line of seeking help is health facilities. So because we have increase we have diffuse transmission of the disease, more people are symptomatic, they are seeking care, hence the increase in the number of tests that we are seeing. But also that said, we built capacity across the country to the different health facilities to be able to collect samples so that people can easily get a sample near them, collected, and then transferred to the testing laboratory. So I would attribute the increase to testing to the diffuse transmission, but also we've really decentralized sample collection and testing across. Thank you very much.
Thank you very much. Prof.
Hello? Yeah. You can hear me?
Yeah, sure.
I think Dr. Susan has mentioned all the key areas, I could say. But it's good to see that people are increasing, the number of people who understand what are the preventive approaches, the SOPs. It's very good to see in the presentation that at least the percentages are quite high. People who really appreciate and understand what are the key observations and behaviors that will lead to the prevention of spread. Because the key thing, preventing is preventing, and those who are infected to have quick and early management and treatment. So I suspect also that since people, because we are doing a lot in educating, sharing information, as more people also understand SOPs, they also appreciate the importance of testing. If people don't understand SOPs, they may not also understand the importance of testing. But I can see they're all going up as we move, and that shows that at least the messages maybe are really sinking into the population because testing is one approach that we can use also to prevent transmission of the disease, but also managing those who are already infected and affected. So the rest, I think Dr. Susan has mentioned, and I won't go into that again. Thank you.
Thank you very much, Prof. Andrew, do you have any observation? She mentioned something about the prices. What can you say about this as someone from private lab?
Thank you so much. Yeah, thank you so much, Jacob. Just a quick comment on observation of SOPs. You realize that we've had several awareness campaigns, and these have enabled us to have this information trickle down pertaining the signs and symptoms for COVID-19 to the population, which wasn't present earlier. And this has enabled us to have a demand for testing. And that could explain why we are having more number of samples being tested at such a time. And also, just as Dr. Susan has mentioned, we are having more labs. By December, we had about 16 labs testing COVID-19. Currently, we have more labs and more testing strategies, like the antigen testing strategy, which were not available before, just as Maria stated. Observance of SOPs and COVID-19 testing, we realize that as the population keeps to observe these SOPs, we will have less people getting infected, just as Doc has stated, and less people will be coming to the facilities, because currently we are focusing on those that are symptomatic. And this will reduce on the burden on the healthcare system. And in fact, it will give us more space to handle our endemic diseases like tuberculosis, HIV, because just as you will see, we are using the same platforms for testing. For example, tuberculosis and COVID-19. Pertaining the prices, it's a serious hindrance because you realize that access to diagnostics is very important to break the chain of transmission. And this is something that we'll discuss. And as we move into public-private partnership, there should be regulation on prices and quality assured testing. I think this is something that the panel will go into later. Thank you so much.
Thank you very much. Dr. Richard, do you have any observation?
I think clearly all the speakers have mentioned most of the points. But what I want to mention is that at individual level, the perception of receiving a negative result, if I went to do a test and I received a negative result, then it's an entry point to positive behavior. We've been, as Ministry of Health, advancing tonsemberera, but if you've tested today and you find yourself negative, then you have every reason to keep yourself negative, just similar to how we do it in HIV. So this by itself can motivate more people to do testing, much as we know that the cost is still high and prohibitive. And I think the issue of testing, when we say it has increased, we need to look at the absolute numbers versus the people we need to target. We've not been also good enough to disaggregate who is testing 3 times, and so we have the absolute number of tests done, even people who are repeating, but we need probably to do better by bringing down the prices, like he mentioned, so that many people can access even private and at public care level. Lastly, the issue of decline in calls to the call center. Call center was an intervention that we used in the first wave at the beginning of the pandemic, and truly it worked so much when information was limited. So as we continue to provide more information, the shift from people calling or call center to people identifying health facilities as their first line of care, I think is a very commendable shift. And in a way, it makes our interventions work, because at the health facility, you get a bigger package in terms of how the people are able to be managed than at the call center level. Thank you so much.
Thank you very much. And thank you to Aweza for that study and the findings. Right now, we're going to start our discussion on COVID-19 testing. And I'll start with Professor Potiano Kalebu, who is the Executive Director, Uganda Research Institute, Virus Research Institute. I want you to give us an overview on COVID-19 testing. And it would be nice if you address questions like how is COVID tested, what are the different tests and how effective are they, what is the capacity of UVRI to test and make research on COVID-19, what are these new variants that we hear about, and do we have the capacity to identify them, and what's the science behind false results? Take it on, Prof.
Okay, thank you. Thank you very much for those questions. Testing, I think we have all the speakers have mentioned the importance of testing. But we need to know, because I think people, because they've been used to other diseases like HIV and the rest, that there's a difference with COVID compared to some of other diseases. COVID is an acute infection. Yeah, you get the virus, yeah, and then the virus disappears. After infection, you'll have the virus, maybe average about 2 weeks or so, and then the virus will go. Yeah, and then after that, you remain maybe with the antibodies and the rest. In COVID, we really want to identify people who are infected, acutely infected, so that we can either manage them or isolate so that we prevent transmission. Unlike HIV, which is a chronic disease, people have the virus all their time unless they are treated. Yeah, so they have the virus all the time. And that's why I'll come later to the use, which assay you need to use. So for COVID, we need to use really those tests that are looking for the virus, yeah, because we want to manage these individuals quickly, prevent spread, and isolate. And there are two major testing that we are using. That's the PCR, polymerase chain reaction, and we use what we call real-time PCR, and that is looking for the virus genetic material. It's amplified, and somebody can use PCR. It's a good diagnostic test when somebody is infected. After infection, it takes a few days, and the virus will be detected using PCR, and that can be used in the initial about 14 days or so. And there are many platforms, and we shall talk about many approaches of using this PCR. And many labs which have been mentioned, we are expanding, using this PCR approach to detect the virus using looking at the genetic composition of the virus. And there are many kits that are now on market that are people using. But of course, we need to ensure that these are good, and one of the roles of UVRI is to ensure these are checked, all the PCR tests that come. Then there's also the antigen. That looks for the protein of the virus. It is also looking for the virus, but it's less sensitive. It's not as sensitive as the PCR. Again, you can detect it in acute when somebody still has the virus, although its detection comes in slightly later and also disappears slightly quicker than the PCR, but they are not as sensitive as the PCR. That's why we have recommended mostly using them in individuals who are symptomatic, so that we can manage them in the hospitals and the health facilities. It's not something we should just use anyhow like the PCR, because you are likely to have a lot of false negative individuals, and that has been one of the problems, because the antigens, they are very good, they are quick, they are rapid tests, you can get results in a very short time, they are very attractive, they are cheaper, but also they have that problem of not being as sensitive. And then the other one is antibodies. When COVID came, there was excitement about our antibodies. We got so many business people who came with the kits that they want to start using them. But unfortunately, they are not useful in this, if you want to look at identifying people who are acutely infected and isolating. Antibodies come on later, maybe after the 14 days I've mentioned. And those detect for past infection. They are good for surveillance, and we're going to use them to see how much people have been infected in the past, and also those who have been vaccinated. But we are not really using them to detect acute early infection in terms of our quick intervention. And there are many rapid tests and ELISAs that are looking for antibodies. So in summary, the best is the PCR. Then we have the antigen, but as I've said, they are quite less, they are not as sensitive, and then we have antibodies. So those are the different tests. How effective? PCR is quite sensitive. It's good. If you have the right kit, you have got the right training, and the right, it works quite well. Capacity, I think, for instance, we have opened up many labs. I think you mentioned now about maybe more than 25 labs now have been opened, and most of these are using the PCR. So there's more access but of course there are challenges of getting reagents. We at UVRI, our capacity a day, especially when we are very busy, we can test about 7,000, 8,000 tests per day. We have a way of expanding our testing to involve more labs. So we can expand, but of course, there are challenges that come with that. But it's good that we have more additional labs. At the beginning, of course, mostly there were UVRI public labs, CPHL, Makerere, but now more private labs have come on, and we need to work together. You did ask, I think, what research is being done at the Uganda Virus Research Institute. The Uganda Virus Research Institute does, the mandate is quite broad. We are the national reference lab for COVID as a national reference lab. We're WHO reference lab and Africa CDC reference lab. And that comes with responsibilities, including not only national, but also some of these responsibilities are regional. We need to support the regions around. So we do diagnostics. We need to ensure that the kits that come into the country are validated, they are good. So that's one of our responsibilities that was given to us. We're also working with other partners, CPHL, the lab pillar. We accredit labs to ensure that the labs that are testing have accreditation. Not every lab just comes up and starts testing. There's a process we go through that needs to be accredited. When it comes and training, when it comes to research, we do a lot of work on the virus itself. We sequence the virus, and we have been providing the country the variants that we have because we look at the genetic composition of the virus and sequence it. We are growing now the virus so that we can do other assays like looking at antibodies that can kill and neutralize the virus. So we have put up all the capacity to grow the virus. We look at immune responses to understand immune responses in individuals who have been infected. When do antibodies come on? When do T cells come on? And also we are going to check those who have been vaccinated. What immune responses do they have? We're involved in vaccine, designing the vaccine. The president talks about vaccine design. We're designing vaccines, but also we're testing other vaccines. And some studies are going to start to look at how effective other vaccines that have been produced elsewhere. Surveillance, we're also doing studies, surveillance to look at how much infection do we have in populations, what are risk factors and all that. We do social behavior studies, acceptance of vaccination, why do people accept vaccines, others don't, and other interventions. We do that. Also, we're going to start studies that have been funded by NIH and others on treatment, including use of monoclonal antibodies. Generally, that's what we've been doing. Finally, the two questions you have, variants, yes, the virus changes, mutates. Every virus changes, mutates as it grows, it changes its composition, genetic composition, and the mutation goes in two directions. It can be to the advantage of the virus, it can be to the disadvantage of the virus. In fact, most mutations are to the disadvantage of the virus, but some of mutations are to the advantage. And that's the problem with these variants. They're to the advantage of the variant, the virus, in that some of these mutations make them more transmissible, severe disease and all that. And those variants, the virus changes, but we're more interested in what they call the variants of concern. And those are the ones that are causing more transmissibility. And some of them, the vaccines that we have may not be as sensitive. In Uganda, we have seen most of the variants. The UK variant, which is the alpha, the South African variant, which is beta. We haven't seen the Brazilian alpha, beta, gamma, but we have seen the delta, which is now taking over from India. We have seen others, variants of interest. We have also seen our own variant, which used to be called the Uganda variant, which is a variant of interest because it has mutations that can cause us to worry. So we have the capacity to do this, and we are providing. Finally, why do we get false results? False results can come because, I don't know what definition of false result. A definition of false result is giving you a test that is not really, it's not the true test. Yeah. But when somebody tells you I was tested here positive, and then I went to another lab and tested negative, it doesn't necessarily mean that is false. It could be genuine, true. You had the virus yesterday, and today you don't have the virus. Yeah. Or yesterday you didn't have the virus, and today you have the virus. So that is possible also because the virus is growing. So it could be genuine. It's not a false positive, but discrepant results. Then also the tests that we use, some are more sensitive than the others. I've mentioned to you, antigen tests are less sensitive. There are many people who will be antigen negative, but the PCR will be positive. So the sensitivity of the assay is also important. Then even with the PCR that we have, some are better than the others. That's why now we are working with our colleagues, mechanisms to ensure that we check on the labs so that they are giving good results. We check on the performance of the test people are using. But also it could be how you collect the specimen. Yeah, you will get nasopharyngeal, oropharyngeal. Yeah, you know how painful sometimes this swabbing can be. Somebody may not have the experience to take the right swab. Another one takes the right. One individual, if two people took the swabs, you could have discrepant results because one does better swabbing than the other. So that is also a possibility. And then finally, of course, sometimes mistakes can occur in the lab through PCRs are sensitive. You could make some mistakes here and get some false positives. So briefly, that's what's happening. It should not alarm so much. We need to reduce so that we don't have many of these mistakes, false tests and the rest, or discrepant ones, but you cannot completely eradicate them. Some are genuine, they can happen, but we are doing everything we can to ensure that whoever is testing provides the best results in the country. That's in summary.
Thank you, Prof. Maybe before I go to the next panelist, what is your comment on, I have a friend who told me the other day that he tested negative, but when he did a scan, an X-ray scan, they told him that he was positive. Okay. What's the science behind that?
That is very common. You know, the disease, the COVID disease is not necessarily as a result due to the virus, but what it does to your immune system. Disorganizes your immune system. What the cytokine storm and the rest, it affects your lungs, your kidneys, every part of the body. Yeah, and then you continue with the disease. The virus, you get it for a short time, about 14 days, acute infection, and then it goes. But the COVID disease, as a result of infection, what it has caused to the body continues. And one of those is the lungs. That pathology, disorganization of the lung will continue. When you look at the CT scan, you look at the part of the lung that's completely affected. You see white, grass-like appearance, sometimes they call it. Yeah. So that means this individual may be PCR negative, doesn't have the virus, but the disease continues. In fact, what we even have what we call the long COVID, which even goes on even longer. So that is true. It happens. You may not have, the virus may have cleared, but the disease continues.
Okay,
I hope that is clear.
Yeah, it's clear. Thank you very much. I'll turn now to Dr. Susan. COVID-19 testing in Uganda. And maybe you'll first address some of the concerns that come from Prof. The question of training, I heard about him talk about the capacity of training of these lab personnel. How do we stand in the country? Do we have enough trained lab technicians? Because one of the reasons that might cause a false result is the capacity of a person drawing a sample. Then how is COVID coordinated in Uganda? Where can one get a COVID test? Who is eligible for a COVID test? What is our turnaround time for our COVID tests in Uganda? And maybe you can give a comment also about the false results, maybe the fake results and faking results, and also the center that was put here at Hotel Africana for testing migrants. Thank you.
Thank you very much, Jacob, for those questions. I'll begin with the training. As you've heard Prof saying that this is a specialized test, In our training, most of the training in molecular techniques is not widely done. And that is why before anyone begins any COVID testing, we request them to go for training to Uganda Virus Research Institute. And initially, they were taking up only 2 people, 2 personnel for the training, and at that time, the volumes were not so many. But now with the increase in the volumes, more people are being brought on board. So as the ministry, we are working out a training program to see how we do in-service training in molecular techniques, working together with UVRI to build their capacity to do this. Because this is something we are going to be with, so it's one of the actions we are taking up. How is COVID coordinated in Uganda? COVID testing. When the pandemic started, the testing was mainly done by Uganda Virus Research Institute, and this is because they were testing many travelers that were coming back through the airport. But as the pandemic progressed, we got local transmission, then finally diffuse transmission. As Ministry of Health, we decided to expand the testing labs, initially beginning with the different public health laboratories, that is CPHL, Makerere. We later brought on more labs, research labs like IDI, JCRC, RACI, but we saw that we needed to build more capacity and decentralize testing to increase access to testing. So more labs were accredited, and as we stand, we have 25 labs, both in public and private. This was all because we needed to increase the capacity of testing and increase access to testing. Around May last year, we really had a big issue with points of entry, so we had to establish mobile labs at Tororo, Adjumani, and Mutukula. But you all know that these are static labs. Samples must be taken to these laboratories. So we had an already existing system of sample transportation and a hub system that you've heard about, where samples would be collected in our different 100 hubs. These 100 hubs are actually health facilities at regional, district, and health center force that have been enhanced in terms of infrastructure and equipment and human resource. And samples would be collected from these hospitals. And because we had not yet had access to testing at those hospitals, we would transport the samples through the normal sample transportation system to the different testing labs. And they would be transported that time to Kampala because most of the labs were in Kampala. So they would use these vehicles to bring the samples to Kampala. So that brings me to the issue of turnaround time that you had raised. In the labs, actual testing is actually 24 hours. And we had set up a testing turnaround time to be 48 to 72 hours, putting into consideration the transportation of the samples. But you imagine if a sample is to move from Moroto to Kampala, that increases the transportation of the sample, increases the turnaround time. And that's why you hear in some regions the turnaround time is longer than in other regions. People in Kampala get their results almost the same day. People up there get results 4 or 5 days later, but we've tried, all the labs have tried to have the samples out in 72 hours. And this made us to decentralize the testing. As we speak now, we are using both PCR and antigen tests. We've distributed all these antigen tests to all our regional hospitals, districts, health center 4s, and health center 3s to really make sure someone can get a result fast. But as Professor has said, not everyone is eligible to have an RDT test. So these are specifically for symptomatic people, and if they test negative, they actually send their samples to the central labs. So the coordination is through the center to know how the cars are moving to bring the samples, but this is reducing because we've taken RDT testing to the lowest health facility. But that also said, because of this wave, we had a lot of cases in our CTUs. So we decided to introduce PCR testing using GeneXpert in all the regional referral hospitals to help them get information immediately so that they can be able to act on their patients. So as we speak now, all regional referral hospitals are testing using PCR. They do an RDT test. If a person has all the symptoms and the test is negative, they subject that sample to a PCR so that they can be able to immediately act instead of sending that sample to the central lab. So we've actually decentralized, and that's how we are coordinating PCR COVID testing. Where can one get a test done? I'm so glad from the study they've done that most people are actually going to health facilities to get a sample taken. And we encourage you to go to these health facilities because, as Prof said, the commonest cause of false, not really commonest, but one of the causes of false negatives could be sample collection. And people who collect samples must be trained people. Ministry has endeavored to train up to the lowest health center 3. But that said, it has also engaged private health facilities to get trained. And all these accredited labs, their sample collectors are trained. So you need a trained person to have your sample taken off. So we request that you go to these designated health facilities, accredited laboratories, to have your sample taken off. We've noted people are moving on borders, in mobile vans, collecting samples home to home. We are not aware about them. We cannot be responsible for that sample taken. We are not aware if they are trained. So we request that you desist having your sample taken by someone who is not a qualified person. Then who do we test in Uganda? Actually, everyone is eligible to have a test. But because of logistics, Ministry of Health strategy is to test for free all alerts. And alerts mean people with symptoms, COVID-like symptoms, a cough, flu, a sore throat, a running nose, headache, for free. And you are requested to go to a health facility, and you are supposed to have a free COVID test if you are symptomatic. And even those contacts of those cases that are symptomatic are supposed to get a free test. And even health workers are supposed to get a free test. But if you have symptoms, you walk to a health facility, that should be a free test. A circular was put out by RPS that whoever wants to just know their status, you are normal and you just want to know your status. Whoever wants their institution to know how the status of their workers is, requested to pay so that they can get that test done, because ministry could not just go and do massive testing using PCR. So that's why they say that all public laboratories, CPHL, UVRI, Adjuman, if you're a public health facility, you are only supposed to test for free if patients are symptomatic. So those who just want to know their status are advised to go to these accredited labs that we supervise as Ministry of Health to get their test for a cost. I'm glad we have one of them here. They'll tell us the issue of the cost. We are also trying to see the issue of regulating such that it can be affordable for those who just want to know their test. And as you said, that hearing the differences in the costs, it depends on what test is being done. An RDT, the cost is definitely different from a PCR test. But we are telling people should know which test should be done in which circumstance. Most people are going out to just screen themselves, know if they have COVID, and they use the RDTs. Prof has just explained to us how their sensitivity is very low, so we tend to get a lot of false negatives. So please use the RDTs for the right people, the symptomatics, to be able to get a right result. Finally, the issue of retesting at Hotel Africana. Professor has actually spoken about why we get fake results. He has given all different scenarios, right from collection of the sample, the testing, and post results. You've all been hearing about planes that leave Uganda, and almost 3/4 of them have positive people who test positive at destination, yet they were negative from Uganda. And from the data, it looked like that most of these that we are testing positive were from these migrant laborers. So as ministry, we decided for interim measures, as we are engaging the Ministry of Labor and the labor associations to find out and come up with final guidelines, we wanted to understand why. So we instituted this exercise for purposes of understanding why, such that we can take informed decisions of the next course of action. So for these 10 so many days, we are retesting these migrant workers before they move, 24 hours before they travel, after getting their own test from their own accredited lab, to understand why if there are any discrepancies. And we hope by the end of this exercise, I think it's soon ending, we shall have information to know if what Prof has explained is the issue, and we see how best to handle. So we shall have a report after the exercise to inform us on the next plan of action. Thank you very much.
Thank you very much, Doctor. We shall get back to you with questions from the media team here and maybe people online. I'll now turn to Dr. Richard Mugai. He's an assistant commissioner at the ministry, but today here is in the capacity of a coordinator, quarantine and point of entry operations. We'd like you to tell us about COVID-19 testing on point of entry. Are we testing at points of entry? And what arrangements have government put in place to test people coming into the country, not specifically, not limited to the airport, but also the different points of entry? And how effective is this testing? And maybe you can tell us what happens to someone who tests positive at these points of entry. What arrangements have we put in place as government to see how we take care of these people who test positive? Over to you, Doctor.
Thank you, Jacob, and all our listeners. The first question about the points of entry. We have a couple of them. These are land border points and our international airport. In this second wave, and even the first one, we are doing testing, and it has been strengthened at the various land points of entry. I'm happy in this very discussion, there's our private sector partners who are supporting us also to carry out the points of entry testing. And these have made the work much more easier with our operations in the second wave compared to how we are doing it in the first wave, especially regarding turnaround time for the results. The operations at the points of entry are supervised by the Ministry of Health, and Ministry of Health engaged formally the private laboratory players to conduct the testing because of our limitations in terms of the lab capacity and being able to give results on time. And this has worked quite well because we supervise it very well, and it's a very robust process. So at the points of entry, there's a clear and systematic way of segregating who should be tested, and there's a formal communication in terms of travelers, categorizing them depending on their countries of origin, Category 1, Category 2, and Category 3. This list of countries, of course, is a list that keeps on being updated depending on the threat. So these countries were selected by the strategic and national COVID response team because of the threat of the variants that were, with the guidance of the scientists, professor, and the team. So the categorization can change over time, but we have clearly countries that are under Category 1, and that is India because of the surge in cases that was happening there. And the country was not allowing any people from India, Category 2. So at the points of entry, we are testing people from countries in Category 2, and countries in Category 3 were where there was no much threat were not being retested at the points of entry. As per the guidelines, the travelers meet the cost of retesting, and I must say this retesting, its intention was to be able not to stop the spread of COVID, because we already had, as Susan mentioned, already had community transmission. But at strategic level, we wanted to limit the number of variants as much as possible, because every time we get a new variant in here, we get a foci of another kind of small epidemic. So we've been able to identify a positivity of around 2% in terms of we've tested more than 10,000 travelers who meet that categorization, and 2% could be around 300 turning positive. The same issue, they leave their countries of origin with negative results, PCR results, but when we test here at our points of entry, we find them positive. Professor at the laboratory explained that it is possible. You can test negative today, and tomorrow you are positive. So the positive samples that we identify at our points of entry, we take them further for a genetic sequencing. And that one was also ably explained by Professor, a system that's only done by the UVRI. So these samples are taken to the lab to see which variants are we getting. So for us who remain with the positives, we take them into isolation centers for management. Majorly, these people are asymptomatic, and they need to go through our management protocols. We hand them over to the case management teams. Some are taken to Namboli. Those who can afford are taken to the private hospitals. And we monitor them until they turn negative and they are discharged out of these isolation facilities. So that is the process that we oversee at the points of entry. And it's a process that's well managed in partnership with our private sector laboratories. Of course, there are limitations, like when we get some travelers who cannot afford, but we've also innovated ways of how we can overcome that, and it's not been a big challenge. We've also had issues of people coming in with forged results of vaccinations, but our system has been able to identify those ones. And for now, I think it's around 5 points of entry in northern Uganda, Malaba and Tororo, Katuna and Kabale, and then the international airport that are doing this point of entry testing. Thank you so much.
Thank you, Dr. Richard. We shall get back to you with the questions and maybe other clarifications that we may need to know. To you, Mr. Andrew Sawoteba, the operations manager in Entebbe Airport Testing Center, and also from the private lab sector. Private lab testing in laboratory testing in Uganda. How is testing coordinated at Entebbe Airport? What is the cost of one testing for COVID-19 in a private lab in Uganda? And maybe you can also make a comment on the quality and the training capacity of lab personnel in private testing laboratories in the country. Thank you. Over to you.
Yeah, thank you. Thank you so much, Jacob. Thank you so much, Jacob. To begin with, the testing operations at the airport, just as Dr. Mugahi has stated, 6 weeks towards the end of April, we realized that we had a gradual increase in COVID-19 cases, and this was an indication that the country was facing a resurgence. And one of the action points that the minister put out in her communication on 30th April was active case detection, so that we know where the virus is hiding, that we break the chain of transmission. And on our side, we are focusing on active case detection among travelers that are coming from highly affected countries, or what we call the category countries, both category 1 and category 2, just as Dr. Mugahi has stated. And these are countries that whose data reveals that they have a high rate of mortality due to COVID-19, people dying, and also high number of cases, plus presence of variants of concern, just as Dr. Mga has stated. In category 1, we have India. Category 2, we have USA, UK, United Arab Emirates, Turkey, South Africa, Kenya, Tanzania, and South Sudan. I think those are and South Africa and then South Sudan. How are we operating at the airport? At arrivals, Ministry of Health in partnership with private health laboratories put a verification desk, a segregation, a document verification desk, a desk at arrivals. And travelers are segregated depending on 3 things: the vaccination status. Those that are fully vaccinated, regardless of the country of origin, are exempted from testing. We are focusing on vaccines that have been recommended by WHO, to mention but a few: AstraZeneca, Sinopharm, Janssen. Prof will elaborate. And those that are vaccinated are exempted. In fact, that's where we get the first challenge of forging of vaccination cards, because travelers know that when they come with vaccination cards, they will be allowed to go through. Ministry of Health is working on having a digital verification system on how these vaccination cards can easily be verified. Apart from vaccination, also the time the person left the country, the time of the last PCR the person got from Uganda. If the last PCR is within 72 countries, for example, someone tested at 7 a.m. From a given lab and moved to Kenya and returned within 72 hours, they also are exempted from testing, regardless of the country of origin. And then lastly, those that are not falling under category 2. We are retesting those that are from category 2. Now, those that are segregated, that are to be retested, they are led to a waiting bus. We have double-decker buses in the VIP waiting parking lot, and box bodies. The baggage is put into the box bodies, and then the travelers sit in the waiting double-decker buses. These are what they call bingo cards, bingo stickers. Everyone's baggage normally has a tag. So we pick off the bingo sticker from the tag and attach it on the bingo card, because luggage is very key in this response. People have precious commodities in luggage. And those box bodies are disinfected 6 times a day to ensure that there is no transmission of the virus. Then the traveler sits into the double-decker buses. These will ensure that there is a space between every traveler for a bit of social distancing. A mask is given to those that do not have a mask, and also hand sanitization is done to maintain the IPC for ministry. The testing site is at Peniel, which is about 5 minutes from the airport, so that will reduce on the transit turnaround time. When the travelers reach Peniel, the IPC measure, Ministry of Health, Infection Prevention and Control measures are ensured. And the first step is to have them sanitized, and those that will have dropped their face masks are given a face mask, and they make payments. The next step is to make payments. Payments are 250,000. I think I should make a statement on the payments. You realize that we have a global procurement challenge of kits, the PCR kits. Some of them are not available in market, and even to get them into the country, given that some flights have been suspended here and there. So private labs face a serious challenge to have these kits come into the country. Then also the PPE, because the whole testing process involves it's an infectious process. So health workers have to be protected. So on the cost of testing in these private labs, they have to ensure that labs have, the health workers are protected. So primarily protective equipment, ensuring quality assurance activities, they come at a cost. Also the human resource, those that are competent, you need to give them some good money to maintain them. Molecular diagnosis is not, it requires a certain skill. That's why the testing is at a given cost. But also for this specific operation, just as Dr. Mga has stated, everything that is happening is at the cost of the traveler. From the bus that has picked this traveler from the airport, to first station of the staff that are handling this staff, this personnel or the traveler, to all operations at the airport. Now the traveler makes payments, whether dollars or Ugandan shillings. We have cash. Someone can pay hard cash, or also they can use a point of sale, what they call Visa, and then also mobile money. After payments, the traveler is led to the sample collection booth. We emphasize nasopharyngeal samples to be collected, whether both nasal and oral. And just as Prof has stated, this is where we normally get challenges with having discrepant results. The technique of sample collection at times is lacking. The person who picks up the sample, you realize that the virus replicates at the end of the nasal passage. Therefore, someone is supposed to insert that swab, that wooden, the plastic shaft, the thin plastic shaft with the swab, deep up to where they find resistance at the end of the nasal passage, or what they call the nasopharynx. But some of the people just swab at the entrance of the nose or the nostrils. They don't reach to the back. And also those that do oropharyngeal swabs, you realize some of the people swab teeth, they swab the gums, they swab the tongues. They don't swab the tonsillar pillars, because some are supposed to move up to what they call the oropharynx area, the posterior pharynx area, or the tonsillar pillars. But what happens is that people swab the teeth and then the lips, and then they pack the sample. So you'll always have discrepant results between labs due to that. We haven't registered any case of severe trauma upon nasopharyngeal sample collection at the airport testing center. After someone's sample has been picked off, the traveler is led to a tent where they wait for results. The maximum waiting time is 4 hours, and the labs, we have both a Safari lab and test and fly lab that are testing at that point. And these labs have ensured that results come out even before 4 hours. In fact, I was looking at the past 60 days, our average turnaround time has been about 2 hours and 45 minutes. But obviously, travelers will count from the time they reached the airport, even before immigration. Someone will say, I spent 7 hours, counting also the time when they started on the process of clearing at the airport. So we've ensured that turnaround time is as short as possible, and so that they don't spend a lot of time there. Then also there is free Wi-Fi at that point. There are charging spots people can charge their phones as they wait for the results for these 3 hours, and also food at a cost plus accommodation services, because there are those that come in the night and will really need to rest. So after someone getting the results, after the 3 hours, they are led to a baggage holding area where baggage is held securely, and still they will use the bingo cards, the passport, the boarding passes, or the passports. They contain unique identifiers that are also available on the bingo stickers that we attached at the airport. So that reconciliation of someone's baggage happens. To date, we've registered one scenario of a broken handle of baggage. We haven't got any baggage loss for the last 60 days of operation. And after that, someone is led to move out of the testing site. In the past 60 days, we've noted, one, there is a reduction in number of travelers that are being tested in the last 1 month. And this could be due to maybe the global uptake of the vaccine. Maybe also Ugandans have got the second jab. It could also be so. And then also maybe the travels. Some flights have cancelled their routes to Uganda, and therefore travel is expensive. So for someone to really come into the country, it has to be an essential reason. And also the lockdown internally could have attributed to that. Then the labs have maintained quality assured testing. We haven't got any serious concern of results, no incidence of a biorisk incidence, maybe fire or serious infection, or at the point of at the testing site. Then also, we are still recording increasing insults by the travelers. Some of them continue to, the abuses, why are we testing? I think we need to create more awareness to them as to why we need to break the chain of transmission through testing. Then also the complaints of not being communicated to before travel, they have reduced. We thank the Uganda Civil Aviation Authority and Ministry of Health that sent NOTAMs and Ministry of works and transport to the embassies of the Category 2 countries to inform them of this operation. In a nutshell, that's how the operation has been going on. Maybe another comment on the cost. Given that it's a public-private partnership, maybe in future, Ministry of Health should look into how the private labs can be supported, maybe on how to acquire some kits. If we begin to manufacture kits within the region and these kits be accessible at a low cost, it will be easier for the private labs also to pull down the cost of operation. On the issue of, and also the other partnerships of private labs, they are not only private labs, but also the private sector. We have the data management systems. They always come in to support building robust data management systems, because that's also very important as far as testing is concerned, and also manufacturing PPE. I'm aware we have some facilities that are currently manufacturing PPE into the country. So that's it's a serious great contribution of private sector. And also the 70%, the absolute alcohol, we have some facilities that are supporting to have these availed to as far as testing is concerned. Back to you, Jacob.
Thank you very much. Maybe we would want to know what are these labs that are testing at the airport?
Yes.
Yeah.
Yes, Jacob. Just as I mentioned, we have 2 labs that 22 partnership Ministry of Health. That is Test and Fly Laboratory, and then Safari Lab. Just as the Commissioner stated, these labs were assessed for competence and capability and capacity for COVID-19 testing.
I think you didn't even respond to one of my questions on the capacity of the training capacity of your lab people.
Of the labs at Penuel.
The personnel.
The personnel. Now, these personnel go through the training, just as you had the previous speaker state. They send personnel to UVRI, and these personnel are trained, went through training, and upon training, that's how they start testing, because molecular diagnosis requires certain skill for testing. So they have a huge capacity of human resource that are competent in molecular virology and also in customer care, because also that is very important.
Okay, thank you. Maybe we shall get back to you on the question of the costs. Maybe at the end you shall give us a proper structure of what are the costs, how much it is for people to know who are following us online in case they want to take a COVID test. I think you talked about the airport testing, not the general testing. I get back to you, Prof. He raises something about exempting people who are vaccinated from being tested at the airport. What is the science behind this? Is it a time bomb? Could they be having the virus and we let them go on the disguise of being vaccinated? What should we know about this?
Hello? I think that's an important one, vaccination. I think the whole world now we have heard that if we are really to manage this pandemic, we need to vaccinate, increase our vaccination. We need to reach some herd immunity, which will come either through vaccination or through natural infection. We don't want people to wait for natural infection and then some people die, but of course that will happen. So vaccination is the way to go forward. And I think there's this feeling that if people are really vaccinated, definitely there are people who are vaccinated who can get infected, and some of it does happen, but at least it reduces on carrying of the virus and infecting others. It's not 100%, but as a public health approach, I think vaccination, we're encouraging people to be vaccinated, and I think if people have their 2 doses or 1 dose for Johnson and Johnson, I think it is becoming now globally, not only in Uganda, that people can be allowed now to move. There's reduced reduction in getting infected, also reduction in infecting others. There's nothing that we can do that will be 100%, But the world cannot stay stagnant. Yeah? That because there's COVID, we cannot move. I think vaccination is one way of making at least the world start moving, people starting moving around. And I think it's a good way. If I've got my two vaccines, my 2 doses, at least I have less chance of getting infected, less chance of infecting others. It's at least one way of intervening. It's not 100%, but at least it's better. And I think it will also encourage people to get vaccinated. We need people to get vaccinated. In the UK, you have heard that now they are beginning to move. Of course, it's controversial, removing their masks. The infections, though, are going up. Severe disease is coming down, and death due to vaccination. I think it's a public health approach, really, to manage the COVID under the circumstances, but also allow the economy and the countries to move forward.
Thank you. Before I let you go, Prof, there are some questions. We are going to the session of question and answers. I'll start with these questions that have come from Zoom, then I'll get questions from the journalists inside here. The first question is on is upon contracting the virus, after how many days can the coronavirus be detected? Then there is a question on if I survived COVID-19, can I get reinfected, especially with the same variant? What are the short and long-term effects of COVID-19 on a survivor? Then to Dr. Susan, how effective are the newly introduced COVID-19 test kits? Were they tested and cleared by UVLI and bodies like NDA? Then the other question is, looking at the fight against COVID-19, health workers are on the front line to save lives. How often do they test? Yeah, I think those are the questions that you will respond to before we receive questions from the journalists here. Over to you, Prof.
How long after infection? Again, depending on the sensitivity. PCR is quite sensitive. The moment when you're infected, the virus starts multiplying. Yeah? If you have a good test, a good PCR, the earliest as the virus starts multiplying, 2 days, 3 days, you'll start picking the signals. Yeah? Some PCRs, of course, may not be as sensitive. It may take you some days. But also, the virus, the way it goes up is not constant. Not everyone's virus goes up at the same time. Some people have high viral loads, others have low viral loads. So we give a range. We don't say this day. We just give a range. And we say PCR could become positive within 3 days of maybe somebody getting exposed to the virus, yeah, and beyond, and up to about 14 days. But we have seen people who are positive, PCR positive, even beyond 14 days. Others who have become PCR negative, even less. But that's the average, in that you're looking at the peak of the virus from infection starts rising up. Yeah, some very good kits can start detecting 3 or 4 days after getting the exposure. So that is how the dynamic. Reinfection can occur, but it's not common. Yeah, there are cases of reinfections that have occurred, but it's not common. Now, that is with the same variant. With the new variants that are coming on, of course, the chances of getting reinfections increase. But all the same, reinfection is not that common. So that indicates to us that the immune response does something to prevent, and that is a good sign for vaccination, but also, I think people should not be worried about it. Yeah? Let people settle. Don't be worried about reinfection. Even if you got reinfection, your reinfected disease will not be severe. It will be mild. So we should not so much if you have been infected before, of course, we are now saying they are likely that you'll be protected. You have some protective immune responses, but we're also saying that infection, even people who have had infection, after some time, if you have a chance of getting vaccinated, do get vaccinated. Yeah? There are areas that are still a lot of studies going on. Yeah, how long should you be revaccinated after infection? Yeah, but it won't do any harm. The people get infected and they don't get a good immune response. You may benefit from a vaccine. Yeah, and the others who get a very good immune response, and you may find you have wasted your vaccine. So there are lots of unknown. But if it's not doing any harm, get the vaccine. But reinfection, people should not get worried. It happens, but it's not very, very common. Short and long term, there are many short term effects of the virus. Of course, people get the fever and all that, some recover. But I think the most worrying one is the effects on the chest, yeah, that leads to difficulties in breathing, low oxygen levels, and the rest. And the disease also causes immune disorganization that leads to sepsis. And that sepsis can affect any part of the body. It can affect the kidney, it can affect the heart, it can affect. So the COVID really can affect any part of the body because of the disorganized immune system. But I think what the most worries us is the chest, whereby you get difficulties in oxygen saturation, oxygen goes down, and you need really to be managed. Longer term, there's long COVID, which again, people are still studying it, but it can affect any part of the body. But also psychological, mental, early on, mental problems, psychological, which also remain for a long time. So I can't say generally that short term, the chest, but also nearly all other parts of the body can be affected. And hence, when they're looking at you, they're looking at your liver, they're checking your kidneys, they're checking your heart, they're checking everything. But also longer term, other parts of the body can be affected. That's the summary, really. Yeah. Physical and psychological. Oh, the kids. Did he say? Ask about the kids. Oh, the kids. New kids. We do a lot of validation of kids. For the PCR, for the antigen, and for the antibodies. Our kits, I think for the PCR, we have, I think, validated more than 12. And those are the ones being used in most of the labs. Different types, BGI, Altona, and the rest. They're kits. The beauty with these kits, when we started testing, we are doing the long PCR. We call it the Berlin protocol, whereby we prepare everything, we order our primers, we order our enzymes, and we still do it as a gold standard. But the newer kits that are now many labs are using, they're made easier. They come already with mixed primers, probes, and all that. And these we do evaluate them. We have a mechanism of evaluating them. Luckily for the PCR kits, many of them have passed our testing. We have samples with dilute. We go to the lowest dilution, copies per number. Many of them are okay, but there are some we have discouraged. So PCR kits we have evaluated about more than 10, about 12, and they are passed. But PCR, it doesn't stop at the kits. Also the platform people use. People are using different platforms. They are using the FBI, they are using Abbott, they are using, which again, the good thing, these also platforms are okay. The challenge has been with the antigen. We have only passed 2 antigen kits, Standard Q and PanBio. But there are many antigen kits on the market, and people come to us. I'm telling you, COVID has brought me near business people, and I've seen how difficult it is to deal with business people. I have quarrels with business people, and they say, I stick to my science. They go out in Germany, Netherlands, and say, this kit is used in Germany. It's FDA approved. Why are you testing? You test it, it's bogus. And in fact, WHO, FDA, they are withdrawing some of these kits. But commercial people, they come, they have brought this kit. We say, yes, let's validate it. Only 2. There's the third, which Commissioner we shall tell you about, which is doing quite well. We may introduce others. But luckily, by coincidence, these 2 kits that we have found best are only now the only kits that WHO is recommending so far for the antigen. So only 2, but there are many. That's one of the things we need to do. There are many labs out there using kits probably that are not. And we are telling the ministry to have some way of enforcement. We need now to come in to enforce, because poor and giving poor services to our citizens is affecting all of us. Now, for the antibody also, business people, when COVID came, they went and brought all the antibody kits to make money. We told them they are not of value in terms of identifying acute infection. They will be good for research and surveillance. They abused us, they did everything, and they calmed down. We have a few antibody kits that we have also proposed, but of course, there are people doing whatever sorts of things we need to just enforce. So I can tell you that we're doing quite a lot. Let me just expand on the labs, the way we do accreditation of these labs. It's also a long process. First of all, the labs, if you have a private lab, you write to the Ministry of Health, to the Director General, that I have my lab that I want to accredit. The Director General, of course, works very closely with the Commissioner here. They write to us, UVRI. Then we send a team, and this team is not only UVRI. Really, we're working together as a team. UVRI, CPHLA, the lab Peter, Makerere University, many of our colleagues who have really been dedicated, working very hard. Then they go and visit these labs. They have a checklist. This checklist is a WHO checklist. You have this, this, and this, and that, including how you are going to dispose of your waste. So it's a long list of checklists. They check. Then they look at your personnel. What type of people do you have? What training? Some labs have everything, but they have no people. He has told you this is PCR, at least people who have trained. So we check also that you have all the people who have trained. So after checking all those boxes, then your team, you say now, okay, you pass that, then your team comes to UVRI for training. They are trained. After training, we send you a panel, a samples that we give you, they're blinded, and then you test. If you have done them very well, then you say, okay, you have done. So we finalize and we inform the Director General, this lab has passed, it has all the requirements, all the equipment, the personnel, disposal, everything, and they have passed the panel that we have sent. And then the ministry does. But the process does not end there. We are continuing. We haven't done it very well. We're going to do it better to continuously assess these labs, sending them proficiency test panels to check that they're continuing to do the good job and also all that. So it's a longer process. Thank you.
Thank you very much.
The issue about testing for health workers, especially the frontline health workers, the ideal would be every 14 days as surveillance to see if you've really got COVID, but it's not really practical. So it's the symptomatics that the normal process, the normal testing strategy, but ideally it will be every 14 days. But there are those like in the lab, we at least make sure surveillance because they are directly interrogating the sample. At least they do it every 14 days.
Maybe, Doctor, one last one. There are always complaints about results that don't turn back, that don't return. In our office, we've always received people who say, I tested, but my results are nowhere. What can you say about that before I receive questions from the journalists?
Thank you very much for bringing out that issue. When we test, all the results from all the different testing laboratories are posted into what we call a results dispatch system. And where that sample was collected, that person has access to download your results and give it to you. So what the laboratories do, they test and put the results in the results dispatch system. So where you tested from, there is a person who has access to download your results and give it to you. So we encourage people actually to go back to where they tested to get their results. So we tend to find a number of results in the system that are not downloaded or printed. So we are making people aware of how to get their results when they test. So in all the different districts, different focal persons have access to this system to print results and give them to the people who are supposed to get the results. Yes.
Thank you very much. Let me have questions from the journalists who are inside here at Hotel Africana. I'll request you when you're going to ask to step either forward on my right or on my left to the seat at this side, so as we can have your questions. I'll start with you, Vincent.
Thank you so much. My name is Vincent Chisiriko. I'm a journalist from Radio 1 and Akabos. I only have 4. The first one. Sorry. Yes. The first one was about the cost of testing, the testing fee. You've always outlined and stated the different tests that are carried out and the varying prices. Without being specific, on what's the minimum or the average price, at least qualified to each of these tests. So that if I go normally the outcry from the public is that someone goes to test, and what they are told, the prices they are quoted or they are given don't match the tests they are done. And when they go elsewhere, for instance, you may do a PCR that's more expensive than an RDT, but someone pays, you pay for a PCR, someone does an RDT. And so many of our listeners are keen and know this. So they're like, they can't argue out a point because they don't know what is that standard rate, at least for a given test. Please clarify this, the pricing and the test. 2, the quality assurance. The quality assurance aspect. You've highlighted the technical know-how of your laboratory technicians without specifying when do you come in to assess and know what they are doing after they have been accredited, as the prof said, is in tandem with what they are meant to. I hope that one will leave it at that point. You can take it from there. Thirdly, is the report here from Twaweza brought out something so good. In just a lapse of a year, we are seeing a slight, an average increase in the number of people turning up for tests. That's, I got the average. The average is about from 15% to 34 point something percent. From my calculation, I stand to be corrected. That in itself leaves out a significant figure of about 64, if I go by my calculation, relating to the statistics from Twaweza here. Now, 64% of the population is a significant figure to me as a science student. And does that give a real reflection? Now if that on the 34% test, does that give a true reflection on the extent of the disease in the populace? From your view as you people testing, manning this exercise, does it bring out the true reflection of what's on ground? Finally, Prof talked about the COVID disease. I've happened to treat so many people from this scourge, but they are crying out for post-illnesses. And I can't really attach them to the pandemic because when we test them, they are negative. So I would like you to spell out maybe 1 or 2 things that could be of help to the public, that these could tell that these are the further illnesses post-cure. Thank you.
Thank you, Vincent. You can leave it on the table. Another question? Let him come a bit forward.
Thank you very much. My name is Julius Kitone from NBS. Just a simple question goes to Director. VRI. There are concerns nowadays about increasing fake results. That's one. I know you have tried to enlighten me about it, but there is also another concern which has captured public attention. That is the issue of the 30% discount, not discount, can I say deduction on the would-be allowances for healthy staff who are fighting COVID-19. Don't you think that it could be also one of the reasons that's why we are seeing some disparities in the manner in which COVID-19 is handled? Thank you.
Thank you very much. Another question? Any other question? Seems there is no more question. I have some here, so as you can answer them at once. Dr. Susan, someone is asking whether government there are any plans. Dr. Susan, someone is asking whether there are plans by government to test children, maybe once we think of reopening schools. Prof, when you talked about the effect of COVID on different body organs and parts, there is someone here who says there is a report from Soroti where MPs were visiting this week. A certain doctor told MPs that they are registering, they're investigating concerns about electrical dysfunction in men, maybe due to COVID. Maybe you can make a comment whether it somehow in any way affect the functionality of men. I know it's a worry once a man hears about that. Okay, you can respond to those questions as we receive more questions. Over to you. I'll start with you, Dr. Susan. If there are some questions that were directed to you, then we shall move like that.
I think most are for the quality assurance and COVID. I'll comment about percentage of people testing. Most people really want to do mass testing, which means you go out and test everyone, symptomatic, asymptomatic, but this comes with so many challenges, logistics, being able to really be able to test. Do you have enough test kits? So currently our testing strategy as Uganda for response is to test those people who have COVID-like symptoms, the alerts, and those that are contacts of those cases and they are symptomatic. And the third category is the health workers. That is the strategy on the side of response. But as I've said, that for those that are testing for a fee, someone who just wants to know their status, they are being tested in the private sector. And in organizations that want to know the status of their staff, together with travelers, but mainly for testing in the public health facilities, we are following our current testing strategy, and that's why you see that is the percentage. It cannot be 100% because not all of them are symptomatic. And we know the percentage that are symptomatic, the biggest is the symptomatic percentage. But it also goes, massive testing goes with logistics and what are the implications of testing everyone. You are negative in the morning and you are positive in the evening. So that's why the percentage is around, it can never be 100%. Then the issue of plans to retest children as they get back to school, the strategies are being discussed on opening the lockdown, and communication will be done depending on the discussions that will be held between the Ministry of Education and Ministry of Health, putting science in it and logistics and everything. So this will be known after the discussions that are going on have been finalized. I think that's what...
Maybe this one also, Doctor. How evenly distributed are the 25 accredited testing laboratories across the country?
Thank you very much for that question. The truth is that most of these laboratories are actually in the center, in Kampala. If I can mention those that are up country, we have Ajumani that is in the north. We have a Tororo lab that is in the east. We have Rakai Health Science Project Lab in Rakai. Then we have Mbarara Epicenter Lab. And then we've just brought Fort Portal Regional Referral Hospital on board. So those are for public health. And then for the private laboratories, majority are in Kampala, but a number of them have set up labs at the points of entry. We have 2 in Malaba, 2 in Busia, 2 in Elegu, there's Mutukula, there's Mpondwe, and I think Chanika. So that's how these laboratories are distributed. But the beauty is that with the RDTs, we've really distributed them across. They would reduce access, and only those that must really do a PCR will be the ones to be sent in the country. Thank you.
Thank you very much.
Yeah, Vincent, you raised important question that I want to address, the quality assurance, because this is very, very important. If we want to provide good services, then quality assurance is a very important exercise. And it's a continuous exercise. It's quite laborious, quite expensive, but we are moving and we are trying. Because if you want to give good results, it involves, you must have good supplies. The reagents that you use are okay. They are not expired. They're coming from good suppliers, continuously trained. People are trained, and not only training, but they continue to do the good job, follow the right SOPs. Your equipments have to be okay. They're well calibrated. They are well serviced. So it's a very tedious exercise. And we have many labs. But we are working under, of course, challenging times, resources limited, personnel limited. A lot of the people working, by the way, on COVID in the public labs, UVRI, CPHL, and elsewhere, they also have other jobs to do. So COVID came on and is part. We don't have many people who are completely only working on COVID. So we have to mix our routine work, because HIV work has to continue, TB work has to continue, and many others, and then add in COVID. But we have set up, the ministry has set up a quality assurance committee with terms of reference, what needs to be done. I chair that committee, and it has many people who are involved, and we're involving many institutions to work with us, the lab pillar, and to ensure that they help us in visiting these labs. In fact, this week, one of the exercises has begun. It began earlier. We have what we call proficiency test panels. Panels that come, we know how many copies of virus they have, and then we give them to the labs to see whether they can test them and give accurate results. WHO has provided some of these panels. African Society for Lab Medicine has also provided, and now UVRI has also started providing these panels. And this week, actually, the team has been going around starting to distribute these panels, working with the other partners. So that will continue, but also visiting the labs. What the commissioner mentioned about these fake, what we call maybe could be bad results that are happening with our girls who are traveling, already we are doing an exercise now. It's part of that quality assurance exercise, even what is happening here at Hotel Africana. So it's quite a lot that is involved. We are not saying we are perfect. We haven't perfected it, but we are moving in that direction to ensure that it's a continuous process. COVID disease. COVID is a new disease. We are learning. Our physicians and doctors are learning a lot. We are reading books every time. We are reading papers to see what COVID does, what long COVID does, and what happens. I think what I can tell colleagues who have been unfortunately infected and affected is to go to our doctors so that they check them. Go to our doctors so that they check you. You may have one of those rare conditions that even some of us have not experienced before, but all we can tell you is that the COVID disease can continue affecting you even after you have been discharged from the hospital, even when you are PCR negative. So I think we need to ensure that where possible, we continue visiting our. So I don't have. I think what this question was about, post-illness help, is just to ensure that we go and see our doctors. Could fake results be a result of this 30%? I don't think. The 30%, I think they're talking about the tax, that allowances are given. The minister is saying, and others are saying, the MPs are saying, let's not tax this income tax of 30%. All of us, our earnings are taxed. They're taxed. So we are used to that. But I think because these doctors, health workers and many others are putting in. They are facing risks. They are saying, can we waive this 30%? I've not had this problem at my institute that people are not complaining about. They're not doing a good job. No. But if the 30% is waived, that would be very good because we understand they are all challenges and risks, and they're doing a fantastic job. Effect on the body, erectile dysfunction. I don't think I've read it for the disease causing erectile dysfunction. It is possible, probably, for the disease. Yes, I think COVID is a new disease. Anything could happen. I think if you Google and check around, you may find some patients who have had COVID having some problem. But what I've not seen, because people also say, even when you are vaccinated, that you can lose your, I think that may not be true, but the disease itself, that's a possibility. But I think if it happens, it's transient, it's not permanent, and then you recover your manhood and continue. Thank you.
Thank you very much. Andrew, part of the things you're going to respond to, maybe you can also respond to this question. How do private labs and private health facilities that use antigens like RDT and PCR report to the system? Maybe the system that Dr. Susan talked about of the General Collective.
Yes, thank you so much, Jacob, and the listeners. To begin with, on the issue of prices, I think it's time for Ministry of Health to come in to regulate the testing prices. You realize that we have some labs that cut prices very low to attract more numbers, and also we have some labs that put prices so high, whereas we are aware of the global procurement challenges of these kits, and it has been reported that some of these labs maybe could even be forced to use cheaper options. Just as you had us state that for us to detect current infection, we need to do a viral test, but this can be done using either antigen or PCR. And the cost of the antigen is different from the PCR test because of many reasons. PCR is a little more sensitive, and a lot of work is done for one to do a PCR test. So the differences in prices could be due to the difference in the test and also the other challenges, the location of these labs and other processes. Also the post-analytical processes. Maybe someone requires the result to be taken to him by a hard copy and all that. But as Ministry of Health, Commissioner, I think Ministry has to set a certain threshold for labs to know that you can't go below this. Prof has elaborated on the question that was targeted to me on quality assurance. It's a continuous process. But you realize that we have currently 25 labs that are testing COVID-19. And we have several labs in this country. The question should be, why aren't all labs testing? Could it be that they all can't access these kits? It means that there is a regulatory framework. These labs undergo assessments. These assessment checklists, the WHO one that we spoke of, that are done, they involve all quality assurance aspects, continuous training and competence assessments, instrument verification. Someone must use instruments that are verified, method verification. Even though a kit has been verified by UVRI, the lab has to do an internal verification, maintenance of this equipment, and the lab pillar has continuously done assessments of these labs, spot-on checks, and most of these labs are at 3-star and above. For example, the labs testing at the testing site at Peniel, the Tebe testing site, they are 3 stars, SLIPTA. Our regional referrals that are testing COVID, most of them are accredited, and the other private labs. So Ministry of Health is doing all what is required to see that these labs maintain high levels of accurate, reliable, and also the issue of timeliness of results. The distribution of labs, Commissioner has been very elaborate, but also we shouldn't forget that we have a hub system which covers 97% of health facilities. Therefore, even if a sample requires PCR at the lowest health facility, we have, Ministry of Health has a mechanism of how this sample can reach CPHL or UVRI for testing. I think I've been able to be a little elaborate on my question. Reporting of antigen RDTs. In fact, before reporting, let me make this clear. Prof was clear that we have two RDTs, PanBio and Standard Q. But we have continuously heard that other non-verified kits are being used in facilities. So, and apart from that, people that do not have symptoms are also accepting to be tested on using RDTs. We've made it clear that the sensitivity of RDTs is slightly lower than that of PCR. It requires those that have a moderate to high viral load, and that is specific among people that are symptomatic. So the listeners and the people watching us should ensure that if you don't have symptoms, please, you know these symptoms, don't move in for antigen RDT tests. You need to only go for RDT when you have symptoms. The reporting system cuts across both private and government labs and is through what we call the eLIF, the Electronic Laboratory Information Investigation Form, eLIF, and what they call RAS. RAS is for aggregate data, and private facilities have been trained, both private and government. We set up a Zoom webinars, and also they are being trained. As these kits are sent to these facilities, they are being trained on how to use them. We shouldn't negate that we have challenges with reporting, but Ministry of Health, in conjunction with private partners, they are closing these gaps through the lab pillar and the supporting development and implementing partners. Thank you.
Thank you very much. Dr. Richard, in case you have some other question to respond to, I'd like you to respond to this one in particular. COVID testing on points of entry, I don't think it is limited to those coming in the country. It also involves those ones going out of the country. To those ones going outside the country, how are you able to know if they have genuine COVID results?
Thank you so much, Jacob, and our listeners. Yes, it's true, the testing is not only limited for those coming into the country, but also it's for our interest that those who are going out of the country also have negative test results. And we have a verification system at the airport that is looks at the system where the results are uploaded. So the testing laboratories that they've been talking about upload all the results, all the PCR results, because PCR is the mode of testing that we recommend for travelers. They upload all the results into an RDS system, a results-based dispatch system, and the result slip of every traveler has a QR code that is counter-verified at the point of exit at the airport. And actually, at the beginning, the system, travelers were trying to get some results from anywhere, including the streets. But this system was able to identify those with fake results from those with genuine results. I'm happy to report that that has grossly reduced or almost eliminated, because if you come with a result that's not in the RDS system, then you're not going to travel. This is for the benefit of protecting our immigration workers who are handling the travelers, to make sure they are not being exposed to people who are positive, and also to the benefit of the travelers who are going on the plane. So I think that system has been checked, and it's working quite well. Thank you.
Thank you very much. If we do not have any other questions, if any, Vincent.
Thank you so much. I just forgotten two things only. The first one is about the recent complaint, especially from the Middle East states, about the quality of our tests. These guys were complaining about Uganda's Uganda's strategy, or maybe the results, Uganda results, yet they have never undertaken any drastic measure, just like Uganda has done. Maybe those in the recent past, the lockdowns and things of the kind. So our scientists did come out to defend the quality of Uganda test results. They just subjected a redo or a retest, our people to a retest. In other words, they conceded in my perspective. So was it a timid position that you couldn't defend the quality of Ugandan results? Because even now, many of those who go, whereas they're quarantined, our results, they haven't gotten a different treatment from the earlier position. They're like quarantined and still doubted in the type of results they have. So what does it speak to you as the officials manning this exercise in the country, vis-a-vis assuring the public that what you do is actually what is right? Because if any state comes up against us and we don't defend our position, rather we just go for what they recommend, I don't know what it means to you as our technicals. Finally, Dr. Mugahi, people are complaining at the airport. I had a brother who came to bury one of our relatives from the UK, and when he was there, he was told if he was immunized and he would go, he would pass the airport. But when he reached, he was ordered to test, and then I told him before the results come, stay here. But the guy had all the documentation. At least is one of the cases I know. What is the right process or procedure for someone coming from abroad with all of the due documents or required documents proving to you that they are tested, they are vaccinated, or they are negative to be let in, not from a high risk?
Thank you very much. Maybe as you prepare to respond, there are other two questions as we close the session for questions and answers. There's a question I think goes to you, Dr. Susan. Are there plans to control substandard test kits on within the country? Maybe also, Prof, you can give your comment. These substandard test kits that are cheap but give false negatives. Then the other question is, when is the full drive for testing going to be initiated? Maybe you can give a comment whether we have any plans to have a full board test for every Ugandan. I think that ends the question and answer session. You can respond, then we go to the last item on the agenda.
Thank you very much for those questions. The issue of conceding to the claims, as I gave in my remarks, when we kept on receiving such information, we really needed data from that side that was not forthcoming. We're asking for all this evidence of tested people that side so that we know the lab, so that we know which particular people are these. It wasn't forthcoming. And before taking any measures, we needed to get data, generate our own data to prove to people, yes, that our system works, our quality is there, or there is an issue. And that's why we came up with this interim measure, and the report is going to come out to indicate where exactly the problem is. So it wasn't about conceding. We needed data that was not forthcoming, and to take any action, you need to be informed, to make an informed decision. So that's why we are carrying out this, and the report will be out on the next steps of these particular people. The other issue of full drive mass testing, and I think I said this, mass testing involves a lot. Logistics, that is first of all the thing to massively test. You must have good logistics to handle everything that will come out, to do that testing, to handle what comes out of this. But also mass testing, if you tested negative in the morning, doesn't mean you will be negative forever. So sometimes it loses out its intention. But also the issue of logistics is the biggest issue. That is why we came out with a testing strategy as Uganda of testing symptomatic so that we can trace and we can also treat those particular ones that are positive. Then the other issue about that substandard test kits and how they come into the market, I think Prof explained, and I will request him to explain, and how we're supposed to work with NDA to really regulate this. Prof, I think that.
About this business of testing, everyone keeps coming. I said at the beginning, COVID is an acute disease. You have it over a short period of time. In fact, your PCR will be positive in maybe the first 2-3 weeks. Yeah? So if you test today, everyone in the country, will that reflect what will happen 6 months later? Just think about it. Think about it. Yeah? It's not like, as I said, HIV, a chronic disease. You take your antibodies, these are positive, but you have your positivity rate today, then what happens after 6 months? Of course, testing in the communities has been done in the past, especially when the pandemic started. There was some community testing to give us some indication. If you do it wisely, it can give you some indication, yeah? But you have to be very careful, is that going to everyone testing today may not be what happens after 6 months. So you have to be, the benefits and the costs, that has to be really thought about very, very carefully. Then enforcement of standards. I think that is where now one of the big challenges that we have. We will do our part. As coming from UVRI, I do my part, and I inform the Minister of Health. And then there are others who have to do the enforcement. We have already discussed this at the ministry, and I've written to the ministry, Director General, to see that the public is complaining about substandard. Let me tell you something. When we started, we all wanted to involve the private sector. We said public alone cannot do this. Let the private come in. And private sector is always very important. In health, they're providing the biggest, maybe, services. But when you bring in private sector also, there are challenges because they're also making money. So you have to have some enforcement to make sure that the private sector does a good job, as they always do, but also they don't go over just to make money. So we want, first of all, NDA to come in. How do these substandard kits come in? We have told NDA, if a kit has not been approved by UVRI and the Minister of Health, bulk importation should not happen. Only a few kits should come in and they are validated. Where do these who are bringing in big bulks of kits, where do they, it's not my responsibility as UVRI, it's somebody's responsibility. So that has to be, of course, the NDA has given some responsibilities to Minister of Health. We need to work together so that this is enforced. We have proposed to the Minister of Health, let's use other key partners like the Allied Professionals Health Council to enforce. And Commissioner, I want this really, these recommendations that we provided to see how they can be implemented. The Allied Professional Health Council has done a good job in the past to check on bad behaviors of labs. This needs to happen. So some of these need to come in, NDA and other partners, to enforce, because we cannot continue because people are making money to provide substandard kits and substandard, and it will counter our efforts to manage this pandemic. It will also give a bad image of the country to the outside. So I agree with you. Enforcement now has to come in. We cannot just watch. Thank you.
Thank you very much. Dr. Richard, you had some questions.
Thank you, Vincent. And as we had earlier explained, the process at the airport is very systematic for travelers coming into the country. If you're aware of the old travelers flow, we have clearly scanning machines immediately from the plane, as you enter the airport premises, there is a scanning machine that takes temperatures of travelers, and at that point, it's the first point of interface. Travelers who have high temperatures, it's a thermal scan, are identified and isolated with there's a port health system and investigated with a standby ambulance. If all the travelers go through that point without any issues, they proceed to immigration, and immigration does its part, well-organized system, and from immigration, they allowed access to go through and get their baggage or luggages. And we have a point of segregation, which I think is very critical in our current modifications at the airport. At the point of segregation, that's where our application of the countries in terms of category applies. And this area is well manned by a multi-sectoral team, including security officers. So at the point of segregation, we have our Ministry of Health team, the laboratory teams, we have security teams, and we've recently even beefed them up. So at this point, this is where we had some bit of challenges, but clearly now there are no more challenges. If the team, the officers there agree that these documents do not meet the standards for you to be in category 1, category 2 or 3. So at that point, you're even offered a ribbon or a sticker for those who are going out and those who are going for a retesting. So your example could have been at that point. I'm not saying that the system is 100% perfect, but at that point, the officers at that point saw that the documents were not convincing enough for this person to go to category 2. The exemption, category 3. So your brother was probably sent to the category for retesting. That's category 2. We have improved. The process is really very fluid. It flows, and there's minimal disturbance because working with civil aviation was on agreement that we provide the travelers a very good experience as we also protect the country from the incoming